Good evening, everyone. My topic for today is biometry in post-radial keratotomy with adjunctive laser-assisted in situ keratomycosis eyes. So I know what everybody would be thinking, that this is a biometry session, so it's going to be all boring with the newer IOL power calculation formulas or the newer IOL machines that we are getting to get more precise calculations. But I think, hold on, we have much in store for you all. So, with all the present instruments and the newer IOL power calculation formulas, we've been getting better and better for the virgin eyes for the routine cataract surgeries. Next in line, we went ahead with the patients with previous refractive surgery. But now, today, we have with us a patient with consecutive different refractive surgeries. So post-refractive surgery eyes, we have much challenges in post-RK eyes because it changes both the front and the back corneal curvature. The standard keratometry overestimates the corneal power. There's a low ELP estimation and thereby underestimation of the IOL power. Following this, in post-LASIK eyes, we have another set of challenges where the anterior corneal curvature changes and the changes in the pachymetry, thereby wrong ELP prediction. Now, there are various formulae which have been used in post-refractive surgery eyes. Some of them use the anterior corneal measurements only, and some of them use both the anterior and the posterior corneal measurements. And now we have web-based calculators like ASCRS calculators also, which gives us a wide range whether we are going to operate a patient with a prior myopic LASIK or a prior hyperopic LASIK or a prior RK. But again, we have no set of formulas which helps us define what to do in patients with post-radial keratotomy along with LASIK. So our patient presented to us as a 43-year-old male who had underwent a radial keratotomy followed by a laser vision correction elsewhere, and came to us for cataract surgery in 2019. Presently, as you can see, that this patient was actually following up with us since 2013 for his retinal follow-ups. In 2019, he complained of diminution of vision in both eye, right more than left, and his present glasses prescription was also available with us. Following this, as a part of routine surgery, we went ahead with the lens-star biometry and noted that we were not able to record any of the keratometric readings, particularly the flat and the steep meridians, so we didn't know which keratometry readings to be used for this patient. Following this, we went ahead with our next set of investigations with the pentacam, and we found out that the K1, K2 readings for the right and the left eye were recorded on pentacam. And as a routine, we look at a post-refractive surgery, the holiday EKR detailed report, which gives us a fair idea about the EKR flat and K1 and K2s with a EKR 65 mean. So we went ahead with the 29.34 in right eye and around 27.62 in the left. Now, again, the question still remains the same, that which IOL power calculation from the web-based, the ASCRS, which is the maximally used these days, should be used, whether it should be the prior myopic LASIK or the prior RK formulas. We thought we'll use both of them, but our challenge was not just limited to this point. The prior RK formulas gave us a wide range between 17.32 till 21.9 diopters of lens powers. And in the prior myopic LASIK, when we started putting the data, we could only get ahead with the OCT-based formula, and no other formula was being calculated by the web-based calculator. A similar thing went ahead with the left eye also, and the range was from 17.5 till 24 in the right, and from the OCT-based formula, we got 23. Now, we went ahead with the manual keratometric readings from the lens-star also, the minimal reading being 30.68. So we entered both the keratometries, and the IOL power calculation came out to be 18.5 and 19. For further evaluation, we went ahead with the eye trace also to look at the aberrations, and obviously the aberrations are very high that the eye trace was not able to differentiate between the internal and the corneal, but it did give us the potential visual complaints post-surgery which we can encounter. So this is the summarization of all the things, that the patient has a BCVA of right more than left with normal NCTs and a wide range of keratometric readings from all the machines that we have gotten ahead with. So the issue remains the same, that in both RK and LASIK, there is no holistic method that we can go ahead with. The central pachymetry seems good, which gives us a good idea that the LASIK ablation was probably minor for the myopic residual RK refraction, and there is a definite central flattening. So now we have a patient with no previous records available, and the LASIK ablation being minor, we are not going to use a Hagees L. We have a double K with no history method to be used here. So we took the average central corneal K and we presumed the historical K as 43.5. The axial length was recorded and the AC depth. And now the point is that we have to adjust the axial length with the Van Cox method with different formulas that are there. And with the right eye, we went ahead with 24 diopters of IOL power implantation. Once we implanted this IOL, we saw that in the right eye, we were getting some minus 0.5 of spherical error as well. So when we were planning for the left eye, we went ahead with 25, erring on a little of a lesser correction so that we don't again go for a myopic correction. So post-operatively, we were very satisfied with the left eye results, and we only got a cylindrical power correction with the BCVA of 6/9. To conclude, now there's no specific one IOL power calculation formula. You know why this is important? Because these days we are getting all these patients with post-refractive surgeries being operated elsewhere, and maybe there are multiple surgeries being done in different patients. So we are supposed to come up with a conclusion for this, that what exactly are we supposed to plan for such patients. So we have to go back to the basics, find out the IOL power measurements, go with multiple IOL power calculation formula, and we have to look into the consistency with each formula. And obviously these patients are post-refractive surgery, so expectation level is very high. They have to be realistic expectations. There are two case reports that have been published in the American Journal of Ophthalmology, in which the first report says the B/F ratio should be considered, and the second one says that particular Hagee's L formula, Sharma's and Barrett's-Truke should be considered, but in our experience, we could not go ahead with. So what our experience adds is that in patients presenting with adjunctive refractive surgeries for cataract, no one formula can be used, and axial length adjustment is a must, along with comparison of IOL power and various formulas. Thank you.
Sir.
This is just a one single patient we are talking about.
Yes, sir.
Had there been more patients?
So basically in our setup, what we've seen, the patient usually comes up with one single type of refractive surgery. So this was a rare case in which we were stuck because we only had one patient. I think we have one more lined up, but we haven't started working up that patient yet. So we are not sure about how we are going to work that patient up.
Going to work out also.
Yes, so that patient, if that one comes along, then we can obviously add. But then otherwise also there were only 2 case reports that we came across, and none of them was very consistent. So we just wanted to add this to the literature to make sure that everybody can have, because these days refractive surgery patients are coming on and off for cataract surgeries presentation, operated elsewhere. So everybody is having challenges regarding the same.
I think it's a excellent study that you have carried out and worked it, in depth.
Thank you.
And I think we should wait for more studies to be presented so that we can come to some conclusion.
Yes, ma'am.
Good presentation.
Thank you so much.
Call the next one.
Yeah.